Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent and reverse brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a functional medicine physician in Cleveland, Ohio, and your host on this journey. So, whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have loved ones with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's and dementia. If you have questions or comments or just want to connect, please check us out on our Facebook page, or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. So here we go. Let's get better. Welcome back. Today we are honored to have a distinguished researcher in the Alzheimer's community, Dr. David Merrill, MD in Psychiatry and a PhD. He's currently an assistant clinical professor, Psychiatry and Behavioral Sciences at UCLA. He is an active proponent of prevention of Alzheimer's and an expert in many of the areas relating to this. It's our pleasure to welcome him to our show. Hi, David. Thanks for being here.
Oh, hi, Nate. Thank you very much for the invitation.
Excellent. First off, I've read several of your articles. You've made some really interesting contributions to the Alzheimer's field. Can you just tell us how you became interested in psychiatry and in Alzheimer's in particular, and neurodegenerative disease, memory and cognition, and all those interesting things?
Well, sure. I don't think it's terribly uncommon in the field. Kind of growing up, I had strong relationships with my grandparents, and a couple of them during my development ended up having neurodegenerative disorders. One grandfather with Alzheimer's, one grandfather with Parkinson's disease. And that certainly led into when I was an undergraduate at Berkeley studying biology, I gravitated towards neuroscience and started working, actually volunteering clinically with dementia patients, an adult day health care center. And one thing led to another, and here we are. It's like, a couple of decades later, and I'm studying and working in the field of Alzheimer's care and dementia prevention. It's like really been surprising to me that I really focus a lot of time and energy trying to help people prevent themselves from getting progressively worse memory loss.
Yeah, I was just reading more about what you've been on diet and BMI, exercise, and what are you seeing right now that have the greatest impact on preventing Alzheimer's and dementia?
Yeah, so, the field is really at a point where it's kind of like the known unknowns and the known knowns. There's no silver bullet, so to speak. There's neither any drug treatment that prevents Alzheimer's, and there's also no lifestyle habit in and of itself that's going to stop or prevent any one particular case. But on the population level, and then even down to the individual level, both anecdotally and then just experientially in the clinic, there's a whole set of behaviors that are considered healthy, healthy behaviors for the body, also impacting the brain positively. And kind of to answer your question, for me, I've found that exercise to me is worth its weight in gold if I can get people to start moving and keep moving physically, whether it's aerobics or strength training or both or balance. But that's easier said than done. It's hard to get people to adopt regular fitness habits at any point in life, let alone when they're facing memory loss and the stress of it.
Yeah. If you, when you have to recommend a so-called dose of exercise, do you have a specific dose you recommend, a heart rate goal, or how long, or how many times per week, or what are your thoughts on that?
Yeah, no, there's been some really interesting research and then, popular press articles following up on that, the most recent thing is that it really doesn't matter so long as you're doing something. As far as a starting point, a lot of this information was developed having to do with the American Heart Association and what's good for cardiovascular health. So in clinic, I'll tell people what their cardiologist might tell them, which is 30 minutes a day, 5 days or more a week of moderate intensity aerobic exercise, intense enough to get your breath, to get short of breath while you're talking, to feel winded, not so you're passing out or falling over, but that you're working out in whatever form people prefer.
Walking won't necessarily cut it.
Well, it's actually amazing that as you get older, a brisk walk, if you actually take your pulse rate, if you're getting up into the over 110, 120 in heart rate, if you do age-adjusted maximal predicted heart rates, that may actually be, more than good enough. That might be great. There was a study by one of my colleagues, Dr. Raji, who was finding that walking 6 days a week, 1 mile, actually preserved gray matter in the brain over a decade. That was in the cardiovascular health study. And we've also found in our cohorts here at UCLA that people who report more physical activity, including things like walking, tend to have more brain gray matter. That's where the cells are in the brain over time. So it may be that a brisk walk is free and available and there if you're able to do it. For people who aren't, I often recommend things like recumbent stationary bicycling, or if they have access to it, like aerobics, like water aerobics, like water therapy.
Oh, yeah. Excellent. So you you anticipated my next question, which was really about thinking about Alzheimer's more instead of a single pathology, is almost a syndrome, a constellation of mechanisms, which is part of my understanding of the reason that no single drug, or even at this point, cocktail of medications or lifestyle adjustments or whatever else people are trying, seem to be sort of the one thing. I know there's at least 36 mechanisms, probably closer to 50 at this point, that are described that are either associated with or are causative for Alzheimer's. So that's sort of amazing. As a psychiatrist, you have a unique perspective on depression and mood disorders, and completely fascinated by this element of as a driver of cognitive impairment, because we know that depression is both a risk factor, meaning you can develop it as alongside of depression, alongside with dementia, as well as something that mimics and commonly mimics dementia. And sometimes it's difficult as a clinician to tease out, well, what's going on here? Is this depression? Is it dementia? Or is this early, or is this just, this person can't think because they're depressed, et cetera, et cetera. Anybody that works on the clinical side, treating patients, has seen this multiple times. I guess my question is, what's your sort of approach to depression versus, in maybe not full-blown dementia, but just even a mild cognitive impairment? Most of the people that are connected with our listenership are people that are either concerned about getting, or are in an early phase, or have somebody in their family or multiple people in their family, and they're trying to do everything they can. So we're just all trying to identify as many things as possible that may give us something that we can do to impact and lower our chances of developing something like an Alzheimer's. So that having been said, depression, what's your sort of approach to depression when it comes to cognitive impairment? How do you tease these things out? And is there a sort of mechanism by which depression links to cognitive impairment or dementia that you're familiar with?
Right. Well, that's a great question. And if I can remember to come back to it, you mentioned the 36 to 50 mechanisms of brain dysfunction with aging. So it's sounding like you've been talking to Dr. Bredesen or some other.
Right. Yeah, Dr. Bredesen for sure, and others. Yes, Dr. Bredesen for sure has influenced my thinking on this.
So I really love his analogy of the leaky roof, of where it's like, if you want to stay dry underneath a leaky roof, you can't just patch like one or two of the holes. You've got to actually address like all the holes, which, it's really intimidating to think of, but it kind of makes sense that the brain, as a really complex end organ, is going to be affected by a lot of different factors, kind of positively and negatively. And it's really incumbent upon us as individuals and as a society to have as many of those factors headed in the right direction as we get into older age. And absolutely, as a psychiatrist, a large number, if not like pretty much all the patients who end up in my clinic, because I'm a subspecialist within a subspecialty, being a geriatric psychiatrist within a memory center at an academic university. So you can only imagine like the lengths to which people go through to get to see me clinically.
Right.
patients tend to have co-occurring depression with memory loss. And a lot of times the question is, what's driving what? What's the primary thing? Is somebody depressed because they're losing their memory? Or is somebody losing their memory because they're getting depressed or because they've been depressed? So I try to put a fair amount of effort into the diagnostics. It's really hard to get people to perform well on sort of classical neuropsychological testing when they're depressed. In fact, if you send somebody for neuropsychological testing to kind of give a pattern of their memory loss, they'll often come back with a confound of like, well, this patient's also currently depressed. So please, treat their depression and then send them back and we'll see how they're doing. So in terms of diagnostics, I've been trying to get a little fancier, a little bit more nuanced in terms of, there's office-based testing of cognitive performance, but there's also doing more and more advanced neuroimaging, both in terms of volumetrics or the size of memory centers and mood centers, and see which parts of the brain have deviate or been changed compared to what you would expect. Like, is there volume loss in the memory center? Is there volume loss in the mood regulating area? Then I might also do electrophysiologic testing. I mean, it's quite intuitive that we all know that the heart is an electrical organ, but we tend to forget that the brain also communicates through electrical signals. And in fact, it's been known for decades that one good way to test the integrity of the brain is to look at EEG or electroencephalography. There are new companies and new evolving commercially available products that allow us to do automated quantifications of brain waves. And so I've actually started implementing that. I think I was, not to toot my own horn, at the risk of maybe I'm too far ahead of the curve, but I was actually the first practitioner to use a quantitative EEG and ERP, event-related potential product that was developed by a company called Neuronetrics. It's called Cognizion. So I think they're about to do some rebranding of their product. But in any case, it's office-based electrophysiology testing, which is then quantified to give you a signal that's either, you can quantify the signal and see whether or not it's a healthy, like normal signal for the brain, or if it looks like there are changes that imply a degenerative dementia. Now, in and of itself, it's neither sufficient nor necessary for this change to be present, but it's one more piece of information. I've had patients who've been having memory problems and they have normal electrophysiology in the brain, and that's reassuring. That says, look, the brain, the cells are still there, the cells are still functioning, but there's something going on. I've had other patients where there's a decline or decrease in the electrophysiologic signal, and that tends to line up with imaging changes that we'll see or clinical changes that we'll see in the testing performance. So it's part of what I'm doing, and we have a cognitive health clinic. And once we kind of have a sense best we can diagnostically of what's going on, then we kind of take that 36-leak approach in terms of definitely trying to prioritize, like what's the most important change to make. If somebody has significant depression, I'll probably try an antidepressant or two. But if they're also physically inactive, exercise, if they're not adhering to a brain healthy diet, like for example, the Mediterranean style diet, we'll try to get their adherence of that to increase. And we'll encourage things like socialization, stress reduction, even computerized cognitive training if they're up for it. But obviously, again, like if
which program do you like? The Positive Neurosciences?
I really gravitated towards the Brain HQ. I guess is the most recent version of Positive Science. Not that I've had anything to do with it, but it just seems to be.
Yeah, and they do a lot of good studies themselves.
Right, exactly.
Not just
it seems to have been the most vigorously tested, the most out there. In terms of being validated and available. They have a free kind of trial version that people can do quite a bit of it just without paying anything to see whether or not they take to it. Because it's kind of like the cognitive training is much like the exercise. It's like, well, what's the best one to use? It's like, well, the one that the patient will do.
Okay.
So I can have all the evidence in the world, but if they're not going to do it, then
exactly. So David, you mentioned two really interesting things that I find fascinating. One is MRI signatures, and by signatures, of course, we mean something that can become identifiable by. So there's things on, just for our audience, there are things that are on an MRI that might be a signature of Alzheimer's, for example, hippocampal volume atrophy or something like that. And then there are evolving signatures, meaning everybody's looking for elements that allow us to identify things like Alzheimer's, and you mentioned even dementia, using a variety of technologies. You mentioned MRI and quantitative EEGs or qEEGs. Can you talk first about the MRI signatures that distinguish depression from something that would be more of a classic neurodegenerative condition like an Alzheimer's or even an early Alzheimer's, like a mild cognitive impairment or cognitive, just something that would explain cognitive impairment that's not like a tumor or an infection or something like that, or B12 deficiency?
Well, right. I mean, it's certainly been a standard in the field of dementia evaluation to do a structural brain scan, primarily as a rule out, as you mentioned, like a tumor or a brain bleed or, strokes or other vascular abnormality. But, more recently, I think in large part because of the ADNI study, the Alzheimer's Disease Neuroimaging Initiative, really showing pretty definitively that the memory center atrophy or volume loss in the hippocampus pretty much is a biomarker of memory loss, and memory loss that could very well be related to Alzheimer's or dementia per se. Now, Alzheimer's as a cause of dementia. So in the more straightforward cases, that will be the signal that's seen. In the more complicated cases with co-occurring depression, you may see smaller or like amygdalar or basal ganglia changes in the brain with volume changes. And then there's just a whole slew of other potential conditions and changes that may occur more cortically, which may or may not be large enough to actually change the volume sufficiently to see a difference, but sometimes they do and sometimes they are present, the cortical changes. Another main thing that I would be remiss not mentioning would be the not captured by the volumetrics is the cerebral vascular disease, or the so-called white matter damage or lesions, and the degree to which that predicts not only memory loss but also frontal executive processing deficits, and then also depression, treatment-resistant depression, so sort of a vascular depression that's quite difficult to deal with. So, as you mentioned, like the hope of emerging tools that perhaps not just volumetrics, but also then white matter disease or white matter integrity. And then ultimately, I think everyone would hope that we would have functional neuroimaging that could advance enough. I mean, it's not ready for prime time. We can't do it yet, but wouldn't it be great to have somebody in a brain scanner, give them a memory task, and then show how the different areas of the brain are functioning as they're trying to remember something.
Well, you do quantitative EEG brain maps. I mean, that's what you were saying you were doing before. And how there is, the people that like Tom Kalura, the brain masters, the creators, the bioengineers of these technologies will sort of point to some of these loose relationships between quantitative EEG and in some cases, some fMRI data. And these have not been validated across conditions. And there's a small amount of data that would suggest that there's some correlation. So you're obviously an early adopter, if not maybe the earliest adopter of using a qEEG in some of the clinical settings. And we're interested in doing that where I am. But
it's funny. I don't mean to interrupt you, but I was in California when, in fact, the leading edge location was actually Kentucky. That's where the company is. So, I'm a lifelong Californian. We love to be like, oh, we're so great, we're Californian, but we're kind of slow on the uptake out here. So innovation comes in all forms and places. So, I think it's a matter of time before, again, I mean, there can certainly be cases of overkill where you have over-diagnostic evaluation where some of these things aren't necessary and don't need to be done and won't be done. But I think it would also be nice to have a set of validated tools across different modalities. So when the case warrants it, that you would say, oh, this would be a really interesting and useful, for example, to do amyloid imaging or to do, the functional imaging that you're talking about. I think none of those are yet ready for clinical use. I mean, they're being studied, they're being tested, they're being optimized. And so absolutely in the clinic, I'm trying to adopt the things that are available, that they're cleared. These are like off-the-shelf options, basically. So were there to become an off-the-shelf version for, the functional imaging, absolutely. I would send my patients when there's a diagnostic question where it could be helpful, but we're just not quite there yet.
Mm-hmm. Well, on the qEEGs, the brain maps that you're doing, how early do you think you can see changes that you believe are going to turn out to be or already neurodegenerative? Or
Right.
Are there connectomic issues that are going on that sort of portend?
It's a good question. I mean, you're giving either me and or the technique perhaps a little bit too much credit in terms of being able to answer that confidently. But I will say that so the field of looking at qEEG, the main signal is called the peak alpha, and that can either be a normal hertz, a normal frequency, that can be decreased frequency. And so, you have to know that somebody's not delirious. You have to know that they're otherwise kind of healthy. And so if that's declined really below a cutoff of about 8 hertz, that's really suspicious of that there's a decrease in the cell number, cell function, at least in the signal that you're picking up. So if somebody comes in and they've got like 11 hertz, like just firing away there, it looks like really good, it really makes me be all the more alert for some other cause or other causes of memory loss, of cognitive dysfunction, other than like a degenerative dementia. And in the ERP, it gets even more esoteric in terms of you're looking at brain stem responses to auditory sounds, and it generates this P300 wave that's been around for decades. I mean, it's been researched for decades. And again, it's kind of like an application question. Is there a way to automate the process of picking out this P300 wave from brainstem signals? And this company, this seems to do it pretty reliably, this product. And they've got basically normative data. So they have mild Alzheimer's patients and healthy patients. And you can kind of compare your clinic patient's signal to those of known either Alzheimer's or healthy control patients. So again, this is still a field, essentially in the clinical case, it's still just beginning to be used, but it's been around for quite some time. In fact, one of the EEG neurologists at UCLA, Dr. Mark Newer, wrote a position paper about this back in 1984 for the Academy of Neurology, and basically was pointing out that like these signals are well validated. It's just a matter of getting it into a product that can be disseminated and used in the clinic. So it's been a nice tool to have. It's not the end all be all for every case, but it certainly has helped guide me in a direction towards or away from a degenerative dementia. So just to go a little bit further with the qEEG, because I think what a lot of people think where this field is evolving, I mean, there's almost like subsections or subpopulations within, let's just take Alzheimer's, where there's people that are concerned about getting it, there's people that haven't. And then there's people that are in the early stages, right? There's people in the early stages. And if we look at some of the ADNI data, we look at some of the other, some of the available literature that's been around now for several years, it looks like some of the changes in the brain and in the body are occurring 10 or 20 or more years in advance of actual, well, I don't remember my daughter, or I'm having trouble driving. Are you picking up or are you noticing? Because I understand this is where we get into speculation and anecdotes. And do you have any type of intuition or hunch that from what you're seeing, either MRI or a qEEG signature or possibly some other modality, whether it's amyloid imaging or whatever, PET scans, are able to pick up things that are more subtle for, let's say you have somebody that's, 60 years old and, their mom developed Alzheimer's when she was 70. And they heard that this stuff starts 10 years in advance and they feel pretty good, still working, not quite the same as when they were 30 years old, but things are really pretty good. They're active, they're eating well. And you say, okay, is there anything you can do imaging-wise that could tell me that there are changes happening, even though I can still pay my bills and I can still, drive a car and I could, I'm not having any impairments in my ability to get through the day. And maybe I've slowed down a little bit. Maybe I have a little bit of trouble figuring the tip, or maybe they're having a little bit of something that they know that's more of a subjective type of cognitive impairment, but wouldn't show up on memory tests.
do you think, from what you're seeing, either specifically on MRI or qEEG, because those seem more available to people than some of like the functional imaging or the amyloid imaging, do you think that you can see things early?
Well, right. So it's a great question, and one that it's not uncommon for spouses or adult children affected, more severely affected. There's usually a clinically affected patient who comes in, like, oh boy, like this person's already like having functional impairments. You mentioned, finances or driving or cooking or shopping or, somebody who's more advanced. And then it's like, well, what about the rest of us? What about, how can we get tested kind of thing? And the field's similarly not fully there or fully in agreement of like, okay, you're at risk, so do X, Y, and Z. I mean, a great example is the genetics. I mean, just recently the FDA is allowing 23andMe to release these ApoE genetic reports to people who are basically, asymptomatic. And so somehow there's the opinion that there's enough information, evidence that it's reasonable for people to know this, that they have a risk allele or two risk alleles. But we also know that the presence of said risk allele for ApoE, for example, doesn't mean you're not destined to develop Alzheimer's because you have ApoE4. And to relate that to the electrophysiology, so there is published data showing that, to the best of my recollection, there's published data showing that if you have ApoE4 risk allele, that decreases the size of the signal of your P300 wave. So wouldn't that be something? Somebody's got the genetic risk, they come in, they do electrophysiology testing, they have a decreased signal there. It's like by then they're in a panic by then. But as you mentioned, I mean, this is a context of somebody not having functional deficits and being able to either, A, they know how to compensate, or B, I would sort of hypothesize or guess that there's enough other protective factors that are on the plus side that's preventing the brain from really having a rapid degeneration. I mean, talking back to Dr. Bredesen, I mean, the idea of like this imbalance between synapse formation versus synapse death, what I really encourage people to do is just focus on creating and maintaining the positives for the brain health and minimizing the negatives, more so than necessarily getting bogged down, obsessed on having one test or the other. Because at the current day, it's still a field in evolution in terms of the biomarkers.
Yeah, well, that's so interesting. So you sort of almost hinted to the idea that, stress, we want to create stress. I know that part of the ethical challenge about, I mean, I'm personally glad that 23andMe is releasing this data to people. There are people that are, that are willing to action on it, and whether it's
right. No, absolutely. And it's very much, I think it's personalized, and that's why they still call personalized medicine, right? I mean, it's basically like some people, to their credit, 23andMe actually really, up until the moment that you get that genetic report, they kind of give you multiple layers and options. Because I was looking at it after I heard about this, and they give you multiple chances to like not get the information. They don't want you to accidentally just have the information all of a sudden. You have to really want to have it. Like you can opt out of getting it now, of ever getting it. They kind of encourage you to meet with your doctor to talk about it, or to meet with somebody knowledgeable. So when done responsibly, absolutely can be kind of a positive motivator. Though there is some published data that on memory testing, now that you brought this up, on memory testing, that if people are told their genotype and they actually find out that they have a risk allele like ApoE4, there's some evidence that they actually perform worse on the testing just from knowing that they have the allele. But that doesn't say whether or not they then go exercise more or,
right.
Diet. So we're totally in the information era, and so you can't really suppress information. I think it's actually good for people to know as much as they can, and there probably will be a day. I mean, for sure there is already. I mean, you can go to these concierge clinics where you pay out of pocket to get this test or that test, but our health system, the jury is still out in terms of having these be covered tests or covered services.
Yeah.
Kind of a higher level of, well, how does it change the management? I mean, that's one of the Radiology Society is doing a huge study on amyloid imaging right now to basically determine, like, are the amyloid scans worth it? Are they going to change people's management? What are the cases where it's helpful, maybe where you're not sure if it's Alzheimer's, and where if the scan is positive, you might prescribe a medicine straight away, but if it's negative, then you might look somewhere else. You might do something else instead.
Right. So, We definitely don't want to create extra anxiety. And if you look at the work of Bruce McEwen at Rockefeller University and some of his proteges, Robert Sapolsky among them on the West Coast, they're showing brain atrophy, hippocampal atrophy, just as a result of hypercortisolism and sustained hypercortisolism. And you have published some work with others on linking genetics to some of the proteomic markers or lab work and some really interesting stuff. One of the things I find interesting is just who is susceptible, right? Who is susceptible? I see just, again, clinically, when people are coming in telling me, I see many, many cases at this point where people, usually in their 50s or 60s, had some sustained period of stress. That was whether that was for 6 months, 12 months, it's work stress or relationship, financial, it's usually some combination of financial plus other stress. Their company got acquired, a partner left, one of those types of things. And then within some short period of time, some short order of time, usually less than a year, they started having memory changes. And I have a number of people that follow with me that in their 50s or 60s, they were diagnosed with full-blown Alzheimer's, selling their business or having to leave work on disability. And it seems that one of the drivers is stress. And I feel like we're Eskimos now, where we just say stress and it doesn't really mean that much, but we need, like Eskimos have like so many words for the word snow. We need to get more sort of sophisticated in our description of stress, because it just is like this word that really doesn't mean anything. Then it's like some allostatic load of something, but it doesn't. I'm wondering what your thoughts on stress as a driver, getting back to this idea of multiple causes, multiple etiologies or causes for dementia and cognitive impairment, whether it's truly neurodegenerative or it's just I can't think, I can't remember, and I'm not depressed. What are your thoughts on the role of stress? Because another gentleman and group at Stephen Cole and George Slavic have done some really interesting transcriptomic studies on stress and the immune system. And do you have any thoughts on stress and its role in neurodegenerative condition, Alzheimer's, cognitive impairment?
Oh, absolutely. It's great that you bring it up. And I can also think a number of cases where the clinical history is basically one where it's marked by either a traumatic event or, more commonly, like you're saying, like a high pressure, high stress scenario or situation that's gone on. Yeah, it's gone on for a period of time. It's kind of crescendoed or ended up really hitting the brain hard, so to speak. And you might do imaging in these cases and find that there's not just the hippocampus affected, but widespread, like much more than you would have thought, like many areas of the gray matter, many areas of the cortex that have just had this toxic effect of a chronic high stress. And I think it does. It's kind of like the snow phenomenon, or maybe like the frog in the water that's heating up. Is like, you don't realize it till it's too late, or it's boiling. So there you go. For sure. I mean, there it's kind of by necessity. A lot of times people then have to exit the stress, like they can no longer function as a CEO, or they can no longer function in whatever role they've been. And then it's just a matter of like any other severe injury. Can you recover from it? And recovery is even more difficult than prevention in terms of the brain, because there are birth of cells, deep in the hippocampus in adulthood, but it's very limited. It's very few. So I think that recognizing the importance of stress avoidance as a brain protective mechanism, I think there's a byproduct. Like if you're doing regular physical exercise and you're adhering to healthy diet and you're being social, you're doing things that are relaxing and enjoyable, those will all decrease your stress level. But right, in the absence of identifying that, like, you need to not live under chronic high stress to preserve not only your brain health, but your heart health, your body's health. Yeah, it's kind of a lost cause unless that's registered earlier rather than later as critical.
Absolutely. The other thing that's fascinating in terms of, because you mentioned traumas, so what I'm seeing is more like the common traumas of sort of midlife, just the trauma of working, and then when things go south. But Kaiser Permanente, as you well know, did a lot of epidemiologic collection of data and publishing in the late 1990s for the most part. One of the things that came out of that study was the Adverse Childhood Experiences Score, and that people that have, so it's a list of 10 questions in its boiled down version, And if the score is 4 or more, the likelihood that people have any number of chronic diseases, including pain and depression and heart disease and cancer and all these things that don't seem to be linked, just having early childhood experiences that are difficult. So, physical, emotional, sexual traumas, somebody they felt threatened growing up on a consistent basis, or they, was all types of emotional turmoil in the house. And then you get points for these things. If the score is 4 or more, the risk of a number of chronic diseases goes up. One of the chronic diseases that goes up is dementia, in Alzheimer's in specific. And I was fascinated by this. It's like a 6-fold. Your risk is 6 times higher to get dementia if somebody had a score of 4 out of 10 or more. So 4, 5, 6, 7, 8, 10 out of 10. And Mario Mendez is another colleague of yours at UCLA, and I have not met him, but I have seen that he's written a little bit about this. Do you have any thoughts on early childhood trauma or trauma in general? I mean, somebody could be 25 years old and be in the military and have severe PTSD that's traumatic and seems would also be a risk factor for developing dementia. Are you seeing that at all? Do you know if much has been? I've seen some literature on this, but not a great amount. People are talking about this clinically. Do you have thoughts?
Right. So, it definitely speaks to this idea of a lifespan approach to body and therefore brain health that begins really prenatally and then shortly after birth and then just keeps going. That all these risk factors are protective factors for the process of aging, and the fact that they seem to be cumulative. The higher you score, the more risk you have for all sorts of ailments, including not limited to dementia, really just shows that the brain is not, the whole mind-body split is pretty artificial, and that the brain is going to be affected just as any other organ would from these negative events. And our only hope can be that intervening, and we can't prevent life from happening, but when there are traumas, when there are events, that people get in for treatment, that they realize that the treatment helps the outcome, that the treatments preserve the body and the brain as time goes on. Mentioning the veterans and the traumas that they're facing, one of the hardest challenges is to get over the stigma of brain effects of war and traumas. And then instead of getting adaptive, helpful treatments like cognitive behavioral therapy, appropriate medications, supportive group therapies, instead of getting those, see a lot of veterans self-medicating, being isolative, being shut down. Alcohol dependence is co-occurring at alarming rates. There's all these suicides that are happening. So untreated mental health stress and problems. I think that data like the Kaiser data just really shows that when these things are happening, that we all need to be alert and on the lookout for getting our loved ones into treatment and getting appropriate care to prevent the long-term sequelae of the earlier events.
So here's an ethical question, like a clinical question for you. It's a curbside consult, Dr. Merrill. I had a patient that she was in her early 60s, full-blown Alzheimer's, and had severe childhood traumas. Her score was like 8 or 9 out of 10. And a trauma therapist once told me if somebody had a score of 8 or 9, they're probably going to need lifelong therapy. But that's very, very severe, apparently. And this woman's score was really high. And I reasoned that this may have been part of what's set her up. And as you well know, people get into this sort of sympathetic nervous system overdrive, and that drives hypercortisolism and a host of other things, of learned behaviors. And those things all give rise to and are associated with memory loss and neurodegenerative disease and Alzheimer's, etc., and other things. And she also had pretty severe anxiety. And the question that we developed, and her husband was really savvy guy and kind of all over the latest and greatest research. And we wondered, can we treat her? So there's treatments, like you mentioned, cognitive behavioral therapy. There are treatments that are coping strategies, and how do I sort of behave my way out of this? I know it's an oversimplification, but how to behave my way out of this. And then there are modalities that are highly evidence-based, like EMDR, for instance, in the case of PTSD and PTSD-related depression. And if this woman did have This woman now with early dementia. So she had actual Alzheimer's dementia. She couldn't drive anymore, and she needed help remembering to take her medicines, etc. And in her early 60s, active, eating right, had a background actually in nutrition. And the question was, could we go and do therapy on her that would somehow revisit these traumas? That's the concept of EMDR. I'm no expert, but the concept, well, do I practice anymore? But I refer out for it from time to time. Is there enough sort of brain tissue or connectivity? And I talked to a number of neuropsychologists about this. Was there enough brain connectivity to even, if this was the idea, this is a part of the etiology of what's driving her to dementia, could this even be attempted? And this was really a conundrum that we had for a long time. And we sought a bunch of different opinions from people that were both psychologists and neuropsychologists and treating both, were familiar with dementia as well as sort of classic depression and trauma. And there's not that many people. Do you have thoughts about, like how to approach these types of situations, knowing what you know about dementia and connectivity and what can happen when people sort of have a psychotic break? I mean, I know there's not a right answer here. Do you have any thoughts about how to approach trauma and histories of trauma with people that have sort of impending or early onset, now early like dementia symptoms?
Oh, yeah, that's definitely a difficult set of circumstances in a case. It probably just comes down to the particulars of the patient, the husband, what specifically is being proposed to try to do, and of course her level of deficits. I would think some supportive trial of maybe even a test process of not even necessarily doing the real intervention, but just seeing if you got the setup there right, and we're going to try it out, like what sort of response she would have and whether or not there'd be any negative effect. I mean, it's the whole first do no harm.
Absolutely. I think that was actually what we went with in the end. We couldn't sort of justify it. I had another question. You mentioned qEEG. The other side of qEEG, the sort of the treatment side that some people are using, is neurofeedback. And I don't know if are you an advocate of neurofeedback?
Well, I mean, it's not somewhere that I go or do in my clinic.
Okay. Have you seen that? So you're not able to sort of comment on the effectiveness of neurofeedback?
Probably not. I mean, I definitely would love it if there was robust, positive effect and great evidence, and I would be an early adopter, as I say.
Right.
So far, I'm kind of stuck with these dull tools that are.
Okay, I got you. Academic medicine, big academia. Right, we do some interesting things, but you're on the West Coast, which apparently it's not the cutting edge, right? Kentucky's the cutting.
Well, yeah. So to throw another thing your way, I mean, like California, I mean, what was just legalized, right? I mean, so there's people are coming in day after day asking me about not just marijuana, but they're like, oh, what about the cannabidiol, oils, this, and which strain should I use or can I use? And I mean, I feel like I want to just start a support group for all these families kind of being inundated with the notion or the option that, there's this
panacea.
New thing. It's gonna,
yeah, maybe it's helpful, but I'd like to know where specifically it's helpful. One other thing I wanted to ask you published it through our sort of mutual colleague here, Dr. Cyrus Raji. You guys published a case study. It was just one case study of one person, but there you speculated something interesting, that there may be a signature, again, a sort of a character, something that looks characteristically like, as that's what I mean by a signature, on an MRI of someone with repeated concussions. And the reason I'm interested in that is because, again, as you know, concussions and chronic traumatic encephalopathy, there seems to be some interplay with the pathology in Alzheimer's disease, though it's probably two separate things, but there does seem to be some sort of overlap. Is this something you think we're going to be able to flesh out, that there is an actual something that can be learned, a signature, so to speak, on an MRI with someone with a big concussion or maybe repeat concussions, that you can actually ferret out on an MRI? Yeah, you can see, oh, this person had concussions. Because when I heard that say that, I was, wow, that was such a new thing. I never heard it. I ask everybody that. How do we find things out? Can you find it on a qEEG? Can you find it on an EEG? Can you find, short of an fMRI, what can you see these on? What's your thoughts on just a standard structural MRI, possibly having a tool then that we could see something about concussion?
So the case that we published on it, I mean, it surprised me. It actually was piecing it together, going backwards. This was one individual who played kind of old school high school football. He would go both ways, offense and defense. He was a running back. He recounted in particular one opening kickoff where he got leveled. He got floored like so strongly, like he caught the ball and got leveled to the point where he blacked out. And then when he woke up, kind of jumped up and ran off to the sideline, not realizing that he'd run to the wrong team's sideline. So he figured that he had over 900 head contacts that were significant to be considered like, oh, you've had a blow to the head, like over his high school career. And then basically he ended up getting a different, he didn't really play college ball. He didn't play professionally. So his personal playing history makes it so he's not actually eligible. Right now, there's a large, I think it's like a 5-center multi-site trial on former NFL athletes who are 45 and over. And they're doing a large study of a lot of former NFL players who may or may not have this chronic traumatic encephalopathy, first identified by Dr. Malu in Pittsburgh. So at some point, there may be a kind of more definitive answer to the question you're kind of asking me. But in the meantime, we had this one case of this one gentleman who's now about 50. And so, several decades later, after having had the developmental experience of having repeated blows to the head, having concussions, at least one severe one and other smaller ones, that when you look closely at his brain MRI and then also do the quantifications we've been alluding to throughout this discussion, the pattern of volume loss becomes distinctive. Now, is it distinctive enough to call it a fingerprint? Like, is this what CTE looks like for everybody? We don't know yet. But again, it's actually decades after the events. It's not like a week after the concussion. It's not going to help determine if somebody should go back to play again or not. But this is more at the degenerative end of the spectrum. Someone's in middle age and older age. And, it's a case study. It's just one case. And what we saw, and actually also fit with some of the more classic radiologic findings for people who've been punch drunk, so to speak, had changes on their brain scan. When you look at it visually, the volumetric changes kind of went along with that. And in contrast, our patient had very much intact hippocampus, and he was somebody who exercises regularly, eats salmon several times a week. He does online competitive chess. So he's doing a lot of those healthy lifestyle behaviors that are protective against Alzheimer's, and it looks like it's working. His over 4 years, we actually saw that his hippocampus grew 5% in volume, as opposed to he had marked volume loss in some of the brainstem areas that might be affected by head traumas. And so he may, in fact, have some mild degenerative process going on from the remote history of the head traumas. But at the same time, he's basically preserving his hippocampal memory centers through his lifestyles.
Yeah, amazing. That was just such a neat case. Thank you for that case. Well, how can our listeners find out more about your work? And if they, for some reason, wanted to come see you, how can you be found?
Oh, yeah, for sure. So there's Google. And then right now, our clinic at UCLA, I have a website, www.qogclinic, COGCLINIC.net, N-E-T, qogclinic.net. And there, I kind of go over the elements of our workup in our clinic and then very basic elements of a healthy brain intervention. And this is you alluded to, it's an academic medical center clinic, but it's very much, it's a Medicare clinic. I try to do stuff that's evidence-based and covered and not promising the moon or any case, kind of just doing a comprehensive workup and then making the recommendations that I can based on the available evidence and then kind of taking it from there with people.
Excellent. What's the most interesting that you have on your horizon in terms of what's coming up?
Well, I'm really just up and running in the clinic and seeing patients every day, including earlier today and tomorrow. So for me, it's a life's work. I find it to be fascinating stuff. In every case, everybody has their own fingerprint. Everybody has their own set of unique factors in play. And so it is kind of fascinating to work through it with people and try to get them doing as well as possible.
Excellent. Dr. Merrill, thank you so much for your time and being with us today. We really appreciate it. So that's our episode. I hope you guys got something out of that. Check the show notes out on iTunes or on our website where we've summarized the key points. If you have questions or comments or just want to connect, please check us out on our Facebook page. Or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. Finally, if you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comment section. It will really help us bring this message to as many people as we can. Thanks, and talk to you next time.